Thank you for allowing me to come today to speak on HIV prevention among adolescents. Today, we're going to take a path through the following overview of epidemiology, barriers, PrEP options, the prevention pipeline, and some youth-centered strategies. 4,000 new infections every day in 2020. 90% of those in adults ages 15 and above, but relevant for this talk, a third were among young people ages 15 to 24. Key populations are disproportionately impacted by HIV, including transgender women, female sex workers, and gay, bisexual, and other men who have sex with men. In 2020 alone, there were over 250,000 new HIV infections among adolescent girls and young women globally, most in sub-Saharan Africa. And this is particularly striking because young women in that region represent only 10% of the population, but accounted for 25% of HIV infections. And in the United States, racial and ethnic minority, gay, bisexual, men who have sex with men make up most of the HIV infections. There remain significant barriers to addressing the HIV epidemic among youth. Undiagnosed infection is one of those barriers. UNICEF in 2020 reported that only 25% of adolescent girls in Eastern and Southern Africa and 17% of boys had even tested in the last 12 months, with rates even lower in other parts of the world. And a household surveillance study of adolescents 10 to 19 found that 40% of those that were identified had been previously undiagnosed. And in the United States, only about 55% of adolescents who are living with HIV are aware of their status. There continue to be low rates of viral suppression that inhibits HIV prevention strategies. In the United States, young adults living with HIV have the highest rates of skipped medication doses and missed medical visits than any other age group. And in fact, in that group, only 60% are virally suppressed. This is a snapshot of the continuum of care in the United States. And you can see that in the age range of 13 to 24, the rates are the lowest across all of the pillars of the continuum. Gender-based violence is another barrier to HIV prevention. Gender inequity restricts access to HIV care and sexual health services, and violence for both cisgender women and for transgender individuals leads to reduced access to adherence and to treatment. You can see here on the right-hand side a snapshot of various countries and the proportion of young women in those countries who have experienced sexual violence. Discrimination, homophobia, and transphobia continue to marginalize sexual and gender minority populations, and this has a negative impact on HIV outcomes. And sadly, discriminatory laws and regulations are expanding rapidly. On the right-hand side, you can see several shameful examples of headlines in the United States in recent months of legislation that's being passed that discriminates against sexual and gender minority youth and their families. There remain many legal barriers to HIV access. In some countries, adolescents can legally consent to sex before they're legally able to access sexual and reproductive health services such as an HIV test or contraception. And you can see from the chart below that within various regions, there's a large proportion of countries that have reproductive and sexual health laws that prohibit adolescents from accessing those services without parental consent. And obviously that is a barrier. In addition to all of those barriers, you have to consider the biological, psychological, social, and neurocognitive developmental influences of the adolescent development period. This is a beautiful slide from Claude Mellons, which she presented last year at CROI. And you consider all of the barriers and all of these influences and how they impact adherence. And that could be adherence to treatment, to prevention, as well as engagement in HIV services and care. So let's look at some of the current PrEP options that are available for young people. Daily oral PrEP is by far the most widely distributed. 2 formulations, Truvada and Descovy. Tenofovir, Truvada, first approved for prevention in 2012 in the United States and for adolescents in 2018, but widely available in many countries. You can see the yellow countries on the map there, and approved for all populations at substantial risk. Whereas Descovy or TAF approved for cisgender gay and bisexual men who have sex with men and trans women, but no clinical data yet to support exposure to HIV through vaginal sex or injection drug use. Uptake of daily oral PrEP, despite the fact that it's widely available, is well below where we need it to be. Just 8% of the new global target for 2025, and in low and middle income countries, only 28% of the 3 million people that we need to get on PrEP were on it in 2020. The chart on the right just shows how far off we are from that target. And access is still poor in lots of other places in the world, but even in countries where PrEP is widely available, like the United States, there are divergent rates of uptake based on gender, ethnicity, SES, and age. Here you can see a snapshot of PrEP uptake in the United States across all age groups. Clearly, we're not doing well in any age group, but adolescents are struggling the most in the 16 to 24-year age range. PrEP adherence and persistence for youth continues to be a struggle. I've listed here 3 recent studies that highlight this. However, this has been the same story for the last 10 years with oral daily PrEP. Adolescents struggle with adherence unless they have continual contact with study teams or with clinical sites. Otherwise, adherence drops off rapidly over time, as well as persistence. So how do we support young people? Well, one of the easiest ways to support them and most widely available is through mHealth. 95% of youth report having access to a smartphone, and 90% go online multiple times a day. My kids, it seems to be all day, every day. And social media use is pervasive around the world. You can see here the billions of people that are on social media platforms connecting around the world. So if we want to support young people, this is one of the ways to find them. One example of an mHealth application that would be used for support of PrEP would be Health Empowerment, developed by Lisa Hightower-Weidman and her colleagues at OneCow. This is a comprehensive digital health platform, HIV status neutral, that provides a community for young people to support their needs. It encourages positive norms, supportive relationships, and can be used to support a variety of different things, including PrEP uptake, ART adherence, and PrEP adherence. This could be used as an intervention, an adherence intervention, but could also be used sort of as standard of care in the background of PrEP use to support people on their PrEP journey. The next strategy is intermittent oral PrEP, which is only recommended for use with Truvada. On-demand PrEP, as it's also called, has been endorsed by several organizations around the world, not yet approved by the US FDA, but recently at least acknowledged in CDC clinical guidelines. The schedule that's been studied has been the 2-1-1 schedule, which is taking 2 pills, 2 to 24 hours before sex, 1 pill after 24 hours after sex, and 1 pill 24 hours after that. So a little confusing, and the question again, based on the developmental needs of youth, is that feasible for them? So there's a study called POEMS, led by Lisa Hightower-Weidman and Keith Horvath, looking at PrEP messaging around 2-1-1. It started with an ecological momentary assessment of youth over 2 months, daily texts to find out whether they looked for sex online, had sex in the last 24 hours, was it spontaneous or planned, etc. Here are the preliminary results that were just recently reviewed at CROI. 120 young men enrolled, high study retention, high EMA completion. But if you look on the right-hand side, strikingly, you can see 71% of participants knew less than 2 hours ahead of time that they would be having sex. And still, the vast majority of anal sex acts were condomless. And so clearly there seems to be challenges in being able to predict sex events with sufficient lead-in time for an event-driven strategy, highlighting either the need for interventions to support this type of strategy with youth, or that maybe this isn't the best strategy. And in fact, when asked their preferred PrEP modality, youth in that study overwhelmingly said that an injection every 2 to 3 months was preferable to either daily PrEP or 2-1-1. The dapivirine ring is another new strategy for young women. It's an intravaginal ring that releases dapivirine slowly over the course of 1 month. There have been positive scientific opinions released for the ring, as well as WHO guidance and recommendations. It's currently approved for adults in Zimbabwe and very recently South Africa, 18 and over in South Africa. So we're hoping that with the results of the next study I'm going to talk about, we'll be able to get an adolescent indication for that ring as well. The REACH study was designed exactly for that reason, to get more information on adherence and safety among adolescents ages 16 to 21 in several African countries. The design was a crossover design where adolescents were randomized to the ring or PrEP, switched over after 6 months to the opposite, and then had a period of choice for 6 months. The REACH adherence support really dove in with adherence. We decided that we wanted to give young women everything that they needed. We gave them more frequent visits. We provided them with drug level feedback, and that drug level feedback was used to discuss what additional adherence support they may need. And they had this beautiful menu of support options that they could choose from, and they could change their options at any time that they wanted. And this led to really strikingly high rates of adherence, certainly higher than any of the adolescent studies that we've seen so far in young women in the African region. The interim results from the first 2 periods were presented at IAS last year, and again, results were very high. But interestingly, Ken and Guri just reported at CROI on the period 3 findings. 2/3 of young women chose the ring in the 3rd period. So the ring was obviously acceptable to them and attractive to them as a product. And randomization sequence was not associated with product choice. Overall, again, the adherence was very high, higher than anticipated, with fewer than 5% of visits categorized as no or low adherence. And high adherence to oral PrEP in the crossover period was strongly associated with the choice of oral PrEP, meaning that if young women felt confident in their ability to use oral PrEP, then they chose that as their option. Injectable cabotegravir is the newest HIV prevention strategy available to young people. Cabotegravir is an integrase inhibitor that can be taken as a pill or an injectable. The injectable would be every 8 weeks after a 4-week loading dose. And it was just recently approved by the US FDA in December, and there are regulatory submissions in several other countries. HPTN 083 and 08401 provide the adolescent supplementary data for cabotegravir, extended safety, tolerability, and acceptability data for adolescents under the age of 18. In these studies, young people take an oral lead-in like the parent studies, then about 6 months of injections, followed by a choice of Truvada or cabotegravir through an open label extension. I don't have a lot of data to report from those studies yet because they're both still in follow-up, but I thought it was interesting just to get a snapshot of the adherence to the oral lead-in, because even in this 4-week period, you can see the decline from week 2 to week 4 in terms of the adherence starting to slip down to the lower percentages. And this supports the fact that this is a population that would really benefit from injectable PrEP. And then you see beautifully that once they get to the injections, adherence is incredibly high, almost 100% across all injections and 100% almost among all against all safety visits. So this is really important. At least this represents those that have finished the injection phase thus far. So where are we going in HIV prevention pipeline? You can see here in this chart from AVAC several products that are in the works or currently being evaluated. Vaginal ring, which I already mentioned, but there are longer acting rings being studied, say 90 days, for example. There are other long-acting injectables. Lenacapavir is one, it's every 6 months. There are other longer acting oral pills, such as islatravir, which is a monthly pill. And obviously there's always hope for a vaccine. There are also new multi-purpose prevention products that are coming down the line, and I think you'll see more in this area that combine either HIV prevention with contraception or STI prevention, et cetera. And then there are additional products and devices that are being studied as well, including douches, implants, microneedle patches that can be used with various products and delivered in various ways. So how do we continue to push forward from here? Well, we have to continue to design and test behavioral interventions that support and improve the effectiveness of biomedical products. In addition to behavioral interventions, we need structural interventions to really get at those barriers that I talked about at the beginning around stigma and social support, mental health, laws, regulatory problems. We have to continue to get a range of HIV prevention products that are available and that are forgiving of non-adherence, and really have adolescent-focused studies for all new forms of PrEP. Several of the latest phase 3 trials are including 16 and 17-year-olds, but my personal opinion is that adolescent bridging studies, adolescent-focused studies, are more developmentally appropriate. But either way that we can get the data is the most important thing. We still need to advocate for youth engagement earlier, for pediatric plans earlier in the developmental stage, and obviously be aware of differential uptake and effectiveness based on population, locale, et cetera. And then the final comment is just to really support what WHO has been asking for the last decade or so, which is to make services adolescent friendly. And this, again, is not just about services, it's about research strategies, research designs, research clinics. To engage youth effectively, services need to be accessible, acceptable, equitable, appropriate, and effective. And until we broadly apply these principles to engage young people, we will struggle to reach the end of the HIV epidemic. And with that, I will say thank you to those that assisted with slides and to all of the young people, particularly, who are willing to participate in this research and help us learn how to serve them better. Thank you.